So I'm Shelley. I'm the Westergard, and I'm a nurse navigator working at Princess Margaret Cancer Centre for the Average and High Risk Ontario Breast Screening Program. So it's been estimated that there's approximately 35,000 women ages 30 to 69 who are deemed at high risk for breast cancer. I can tell you by working through the high-risk program for the past 4 years that we are nowhere near capturing 35,000 women. And part of that is because the public and healthcare professionals are not aware of the high-risk program. So we do encourage people to be referred. High-risk screening will detect 17 breast cancers per 1,000 women screened. I can tell you that at Princess Margaret, we have over 1,300 patients enrolled, and of those, 20 to 25% will come back with a breast cancer. Women at high risk develop breast cancer at a younger age than the general population, and they have more aggressive cellular changes than the average population. And when the breast cancer is caught early, the survival rate is 87% and beyond in 5 years. So there's less than 1% of all females that will have a lifetime risk score of 25% or greater. And they are at 2 to 5 times a higher risk of developing breast cancer. So just a little bit of a background on the High Risk Ontario Breast Screening Program. Cancer Care Ontario and the Ministry of Health of Long-Term Care worked in partnership to conduct a survey of hospitals that would offer breast MRI services to determine which met the minimum eligibility criteria. And then the regional cancer programs worked in conjunction to assess that each of the site would be able to accommodate the capacity of those women deemed at high risk so that we could provide mammograms and MRIs. And each of the site are equipped with genetics counselors. So initially there were 19 sites in phase 1, which started in July of 2011, and we progressed to 27 sites at present. So as it's been said multiple times, there is 4 eligibility criteria to be enrolled into the high-risk program. So one is being a known carrier of a deleterious gene mutation, and it's not limited to just BRCA1 and 2 carriers. We have people with CDH1, Cowden syndrome, neurofibromatosis, and so on. If you have a first-degree relative and choose not to be genetically tested, you are welcome to participate in the high-risk program. Those that have been deemed to have a lifetime risk of 25% or greater. And then the final group are people that have had chest radiation. And it's not just limited to Hodgkin's lymphoma, but if you've had a Wilms tumor, for example, that was treated. So in order to be enrolled in the program, we do need a physician's referral. So they would need to fill out the High Risk Ontario Breast Screening Form, which you can access through the Cancer Care Ontario website. Women need to be between the ages of 30 to 69. However, we do enroll patients at the age of 29 and a half to start screening if they meet one of the eligibility criteria. And as was mentioned earlier, if they fall into category B, the patients would be first assessed through a genetics counselor and then would be enrolled based on those results using an IBIS score or a BOTA-SIA plus minus genetic blood testing. So we do annual breast MRIs and mammography screening. The mammography screening is utilized to assess what's happening in the fatty breast tissues, and the breast MRI looks at what's happening in the dense breast tissues, lobules, and ducts. And it's the combined screening that picks up early changes, and our goal is early detection and prevention of breast cancer. The guidelines are that it's done once a year. However, most sites are equipped with a nurse navigator, and it allows for us to follow patients if they get callbacks or 6-month follow-ups. Now, in terms of the trajectory here, what happens is once a patient has her initial screening with a breast MRI and mammography screening, if there are abnormalities, then the nurse navigator does contact the patient and educate her about the results and what she can expect from the callback assessment. We also follow patients along their full trajectory. So if there is a cancer diagnosis, we are with her along the entire pathway through diagnosis, surgery, chemotherapy, radiation, and then back to screening, or if she has breast mastectomies through the completion of surgery or through palliation. So this is just a picture of an MRI image. And the other times, because I know I'm running out of time, I'm getting the time out here, is that we don't do screening during breastfeeding and while pregnant. And the reason for that is because we do use a contrast for the MRI. It does pass the placental barrier, which could pose danger to the baby. The mammography screening, while it is digital and there's very little radiation associated with it, we don't want to expose the fetus. Secondly, during breastfeeding, the breast ducts are activated, so everything lights up like a Christmas tree. So it's extremely hard to look at the breast tissues, lobules, and ducts. And then during cancer treatment, we would hold the screening until completion and resume that 6 months later. And then just in terms of what we do is we guide and direct patients, we educate them through each portion of the treatment trajectory. We advocate and link them up accordingly with all of the subspecialists, and we provide psychosocial support along the way. And that's through everything from, where to go to find a wig, who do you find for child care if you don't have child care support. So we would use places, like Nanny Angel, for example, and all of our co-partners that are here today. And it takes a team to move a patient through her trajectory. So as you can see, it's our surgical coordinators, our reconstructive coordinators, our plastic surgeons, medical oncologists, and so on and so forth. So I'll close at that. There's a lot of information. Please feel free if you have any questions to ask me after.